Welcome to the second part of the ovarian lecture. We're going to discuss the rest of the ovarian lesions, but first we're going to go rapidly over what we have discussed earlier in the first part, okay? And the first part, we mainly discussed how to find the ovary in the first place. Most of the lecture was about how to see the ovary in the first place, okay? The ovary looked as such, okay? It is a oblong oval structure, okay? That has little circles inside as if they are little marbles or something, okay? And it's also related to the iliac vessels and how to find it, as it is both ovaries are located on both sides of the uterus. Then the transverse view here was easier to find it, okay? Now we've learned how to find it in the transabdominal approach, okay? And we said that's easier to start by the transverse view, all right? And we would know that it is the ovary by its shape, and it is related to the iliac vessels, as we said, and that it has this form, okay? It has a long shape with little circles inside, and it's closely related to the iliac vessels. Then voila, that is the ovary, all right? Look at this, both of them are on both sides on the uterus. As we said, it's easier to locate it by the transverse view at first, okay? Then you can angulate your probe to look at each one of them, the left and the right. All right. Then the approach by the transvaginal, first you have to locate the uterus by the LS, and then the transverse view, and then you trace the tubes, okay, to find the ovary. Voila, that is the ovary. And you make sure by the fact that it's closely related to the iliac vessels, and you can verify this by the Doppler, okay? It's an important relation, okay? It's in relation to the iliac vessels. You can trace it along the iliac vessels, all right? This is how you would angulate the probe to the contralateral leg in order to see the ovary. Of course, we have said all this in details, okay, but we're just going through it rapidly in order to revise it. Now, the dimensions, the maximum dimension should not exceed 5 centimeters, and the volume should not exceed 10 centimeters, 10 cc. Now, we went through very interesting parts, the coupling or the synchronizing between the ovarian and the uterine cycle. Now, when the female patient comes to the examination, you would find the ovary in one of these phases, and you can verify this by the uterus, okay? They will be similar. Now, this is the ovarian cycle synchronized with the uterine cycle, okay? Now, both of them will exhibit changes according to the cycle. Now, first, in the early days of menstruation, when there is still some content in the uterus, that is the contents from the previous cycle, okay, when the female is in menstruation. Now, the ovary would look as such, okay, no certain changes. That's the early follicular phase. Now, this is the follicular phase when there is a dominant follicle start to enlarge, okay, and the uterus will be the proliferative phase. The individual will start to thicken, okay? Now, here in this phase, there is the imminent ovulation. Now, we have the follicle, okay, and the oocyte inside, what is called the cyst within cyst, okay? This is the imminent or ovulation. Ovulation is just about to happen. And now the uterus will exhibit here proliferation, and there is the appearance of 3 layers, the sandwich appearance, okay? This is the early secretory. Now here, the ovulation has happened and the corpus luteum is formed. Corpus luteum is the follicle after rupture. And how would we know that ovulation has happened? There will be free fluid. We will see the corpus luteum with blood clot inside. Okay, it would be like the follicle, but its wall is irregular. Okay, it has just ruptured, and there is some free fluid. And the patient would say that she had pain in the side of the ovulation. Okay, and here this is the secretory phase. We start to see this echogenicity on the periphery. Okay, and then here the corpus luteum, it has the ring of fire appearance. Okay, and here there is a thickening of the endometrium. Okay, so this is the here this is the luteal phase. All right, so here is the coupling or the synchronization between the ovarian and the uterine changes. Okay, that we're likely going to see in the ovary and the endometrium. Okay, this is really important. Okay, now to the blood supply, we said that the ovary receives blood supply from two sources, the ovarian artery, and also it would receive a branch from the uterine artery. And this was of special importance in the torsion, as we have discussed in details. Right, then there was the simple ovarian cyst. It was the simple pathology that we have discussed in the previous lecture. Now, from its name, we can detect its characteristics. We said that this is simple ovarian cyst. Okay, simple meaning that it is anechoic, that's to say black, all right, and it has thin wall, and it has posterior enhancement as such. So these are the positive three things that we would see in order to say this is a simple ovarian cyst. And we have four negative things that we have to make sure that they are not present. There is no septi, there's no septations, there is no soft tissue nodules, there is no calcification, and most importantly, there is no vascular flow inside. Okay, these things, these 7 criteria would make this ovarian cyst simple. Any other thing would make it complex or complicated, as we see in today's lecture. Okay, now what happens when we find such lesion? Okay, this depends on the patient. Now we said that we will put the patient in one of two categories, whether she's high risk or low risk. We're not going to memorize it, we're just going to place her in the chart. Of course, simple ovarian cyst has to exceed 3. Otherwise, it would be physiological, okay? So it has to exceed 3 centimeters and it has to have the 7 criteria we just cited. Now, what to do after we find it? We will place the patient, either she is low risk or high risk. Who are the high risk group? The high risk is the postmenopausal or a patient with a history of breast or ovarian carcinoma, or she has positive genetics for the breast or the ovarian carcinoma. These 3 criteria will place the patient in the high risk category. Of course, as we said, we will not memorize this. We just place the patient in one of these 2 categories, and accordingly, according to this chart that we're going to print or going to save in our mobile, okay, we will know how to proceed. All right? Okay. That was what we have discussed in the previous lecture. In today's lecture, we're going to see what if it is not simple. And the first thing is the hemorrhagic ovarian cyst. Okay? Now, have we discussed any cyst before that has hemorrhage inside? Yeah, voila, we have. That is the corpus luteum. We said that the corpus luteum has bleeding inside or has blood clot, as we've said, okay, after the rupture of the follicle. But the cutoff is what? The 3 centimeter cutoff. We said that a simple ovarian cyst has the cutoff 3 centimeters. Also, the hemorrhagic cyst has the cutoff 3 centimeters. If the corpus luteum, something looks like the corpus luteum with blood clot inside, exceeded 3 centimeters, then yeah, it would qualify it to be a hemorrhagic cyst and no longer a corpus luteum. Yeah, it could be a corpus luteum, but it's a little bit large. Okay, this is very common, but this would place it to be a hemorrhagic cyst rather than just corpus luteum because it has exceeded the 3 centimeter cut off. Okay. Now it is no longer simple. It is no longer physiological. If it exceeded 3 centimeter, then it is a hemorrhagic cyst, and we might call it hemorrhagic corpus luteal cyst if it looks such, right? Okay. Now to the patterns of the hemorrhagic cyst. The first pattern is this pattern, the lacy appearance. The lacy appearance, okay? Now this resembles a reticular appearance or network. You can see this little spider, okay? Just to demonstrate that it looks like a net, or as we said in Latin, this is reticular. This means net in Latin. So yeah, this is how it looks. Okay, so this is reticular or lacy. It looks like laces around here. Now it's important here to note something. These laces or this reticular reach the margins or the borders of the cyst. Look at this, it reaches the margins or the borders, as in here. It reaches the margins, or because later on we're going to see a cyst, lacy appearance as such, but short reticuli that does not reach the wall and be something else. So here it's important to note that this laces, okay, or this reticuli or this appearance reach is connected to each other, okay, and it reaches the wall. Now, this is one of the appearances of a hemorrhagic cyst. But there is a very important thing. This does not exhibit vascular flow inside. Okay? This does not exhibit vascular flow. Look at this. Another example. Here, there is the septi, okay, or the reticuli. But look at this. They're connected to each other and they do reach the wall. And they have no vascular. Look at this. Now, we have here activated the Doppler function, okay? And there is no vascular flow inside. This is important because any vascular flow inside would make this not a hemorrhagic cyst, but rather a tumor, as we will see later, okay? So here, another example, okay? This is to verify that there is no vascular flow inside. It is of utmost importance that you do know how to calibrate your settings in order to see whether there is flow inside or not, because this is crucial in diagnosis of the ovarian lesions, okay? So should your machine does not have this function or you don't know how to do it, this will make your diagnosis very, very defective. In order to know how to set your machine right, there is a lecture named Machine Settings on the YouTube. It is very important to check it, and this will make you know how to control the Doppler functions and to set them right. This is another example, and this is also to demonstrate that there is no vascular flow inside. Reminding you, this is of utmost importance because this would make the prognosis very different. Should there be a vascular flow inside, this would mean that this is an ovarian tumor, and then the patient would carry on and have an MRI or excisional biopsy. But here, she might just have follow-up, and that's it. So, see, there is difference in the prognosis, so we should really know. All right, so again, there is the example of the lacy appearance, all right? The lacy appearance. Okay, look here, there is posterior enhancement. Yeah, this is a cyst. Now, this is another appearance of the hemorrhagic cyst, but here we've got the fluid level. Okay, now, as we know, this is a hemorrhagic cyst, so there is blood inside, hemorrhage. And hemorrhage can appear or can make the sedimentation, okay? As in, if you are in your lab, remember, okay, when you dealt with this and you have a blood sample, okay, and what will happen to the blood? It will make the sediment inside, and then this the clear serum or plasma upwards. Okay, so yeah, this is the sedimentation, and here the same applies. There is some sedimentation or some precipitation that will make the hemorrhagic cyst look as in with a fluid level. Okay, so this is one of its appearances. All right, now here, this is, look at this again. We have this fluid level when this is fairly more echogenic. The lower part is more echogenic, but the upper part is nearly anechoic. Now, this is important because later on we'll see cyst looks exactly the same, but the upper part, the darker part, is not so very black. Okay, so know that here, this is how it appears. The hemorrhagic cyst, the lower part, the part with the increased echogenicity, okay, as such, and the upper part is nearly anechoic or black. And this is how it looks, okay, when we change the view, right? Now we'll see the orientation would make it different, whether we see it transvaginal or transabdominal later on, how this will make it look a little bit different. Okay. Now, this is the third appearance, and that is the clot retraction. Remember this as in the corpus luteum. Okay. This looks as if it is a solid component. Now, I'm sure that you're quite smart and intelligent and know how to know that this is a not soft tissue component, and that is not a tumor. Huh? Why is it not a tumor? Bravo, because it does not have vascular flow. Again, the vascular flow. All the appearances of hemorrhagic cyst does not exhibit vascular flow inside, including this, because this is, yeah, it looks super weird, and this can be a soft tissue nodule or can be a tumor because, you know, it looks heterogeneous and it looks just as if it's a soft tissue, but it does not have vascular flow. So this is merely a clot, okay? This is merely a clot, and this is one of the appearances of the complex cyst named hemorrhagic cyst. Again, it can be hemorrhagic corpus luteum cyst, and this we see very common, and the majority of cases that would be the case. You know, that would be the cause of this hemorrhagic cyst. It would be with the clot inside, but we have to verify that it does not have vascular flow, and we have to measure it and write it down for the patient. Okay, as we would see how to do to deal with the writing. Okay, another example. See here, this is an example, and we see that the vascular, the Doppler function is set right because it can detect all the flow. This is important. This is important because if you not calibrating right the Doppler, you might miss on some vascular flow inside. Okay, and just like the corpus luteum might have some vascularity outside, never within. Okay, never within. Of course, you can here be more sure that this is a corpus luteum hemorrhagic cyst because it looks as the corpus luteum with vascular ring outside, okay, the ring of fire, and does have the clot inside, but no vascularity inside, okay? Okay. Now, look at this. Now, as we have said, that it's important to calibrate it right. Now, here in this picture, we can hardly see any vascular flow outside or inside or anything. So this means that probably the speed here, the BRF is not set right, so it didn't detect any color flow anywhere. But here there is some color flow, so it's important to set the parameters right, okay, in order to determine, yeah, this have vascular flow or not. The calibrate might be the settings, not the lesion itself might have vascular flow and you fail to detect it, right? So look at this, look at this. What about these soft tissue nodules inside this cyst? Okay, Are these soft tissue nodules or clot retractions? Look at them. They look as cauliflower masses, very suspicious. But look at these. These are cauliflower masses as well, which is neoplastic and which is just hemorrhagic cyst. What will tell us? Again, it is the Doppler, the vascular flow. Here, all of these look really, really super suspicious. They do not exhibit vascular flow. So these would be merely clots, and this is a hemorrhagic cyst, okay? But these, they do exhibit vascular flow. So this is neoplastic, this is tumor. And of course, the prognosis is really different. So again and again and again, it is really very important to determine whether there's vascular flow inside or not and write it down. Okay? All right. Another appearance, okay, might be together. Now, this is the appearance of the lacy appearance, the fibrous strands, and the clot retraction, both of them. Of course, as we know that the blood has these temporal changes, you know, and they tend to have different appearances according to time, and this is all with the body, okay? So here, yeah, this is some fibrine or some strands or some lacy appearance along with the clot, okay? So this is all, so long as there is no vascular flow inside, again, this is just hemorrhagic cyst. So the hemorrhagic cyst has got three appearances so far. Okay, it can be lacy or reticular. Remember the spider web, and it can be fluid level with some sediments. Remember that it has this echogenic part downwards and here almost black or anechoic upwards, and can have clot retraction. Okay, some clots inside that looks gray as such and might be very tricky and very suspicious, but in all of the three, there will be no vascular flow inside, no vascular flow inside. Okay, or it can be mix of both as in here, right? So these are the appearances of the hemorrhagic cyst, okay? How they look. Again, this is some changes. If the cyst show temporal changes, this would verify being hemorrhagic. If it was like this lacy appearance first, and then there's part start to degenerate or to be cystic inside, okay, then this confirms it being hemorrhagic, again, without vascular flow. Okay, look at this. This is the corpus luteum that looks exactly like the hemorrhagic cyst with a ring of fire. Now, the cutoff is the size. If it is more than 3 centimeters, it would be a hemorrhagic corpus luteum cyst. If less, it would be merely corpus luteum. Okay? Okay. Again, more appearances. Now, here is the sum up of how they look. It can be as such, lacy and lacy here. Looks like clot retraction and lacy with a ring of fire. Now, if I see hemorrhagic cyst, all right, now, what do I tell the patient? Again, we would place her in one of two categories, okay? If she is low risk, that's to say she's premenopausal, it's got no risk factor. And if she's postmenopausal, okay, and has family history of breast or ovarian carcinoma or some genetic predisposition, just as like the simple ovarian, okay? The same chart. But here in the hemorrhagic cyst, the number there was what was 7 centimeters. Here the number is 5, okay? Here, if it is less than 3 centimeters, then okay, that's just corpus luteum. If it is more than 3 centimeters, we mention, but there will be no follow-up, just we'll mention it because it's almost certainly benign. But more than 5 centimeters, then we will ask the patient for follow-up. Follow-up would be within 6 to 12 weeks. That is to say, after one cycle, okay? After after 1 or 2 cycles. If her cycle is near, okay, we would ask her to come in after the future cycle, okay? That's to say within 6 to 12 weeks. Okay, so if she's in menses or her coming cycle is quite soon, then she will come after the future cycle. Okay, and if it is resolved, then okay. If it is not resolved, then this would make her qualify or merit doing some further investigation as an MRI. If she is high risk and more than 5 centimeters, then it is follow up from the beginning. Okay, if it is more than 5 centimeters, then it is MRI or surgery right away. If she's high risk, any cyst would merit MRI or surgery, histopathology. Okay, so here the number, the magic number to remember is 5. Okay, of course we'll not memorize this, we'll just print it out just like in the simple cyst and then place the patient 1 to 2 categories and accordingly we tell her what to do. Okay. Okay, on to the next lesion, the endometrioma or the chocolate cyst. Okay, what was this? Okay, let's remember together. Okay, now this is the uterus. Okay, and inside it there is the endometrium. Okay, all right, the endometrium. What if the endometrial cells migrated inside the myometrium? Okay, and what if it migrated out of the uterus? This is called what? This is called endometriosis. What? That is the migration of endometrial cells outside endometrium. If it migrated inside the myometrium, we know this condition by adenomyosis. What? Adenomyosis. And if it migrated to its neighbor, the ovary, then it would make this endometrioma. Okay, the migrating endometrial cells would produce the endometrioma, also known as the chocolate cyst, because of how it appears. Chocolate cyst. Okay, all right. So let's see how it looks in the ultrasounds. All right. All right. Voila. Now the endometrioma has got the word or the color gray written all over it. Okay, we can remember it as such. It is gray. It is a cyst that is gray. Okay. All right. It's a cyst, but it's gray. Now we call it ground glass or gray. The difference between the simple cyst and the endometrioma, simple cyst is completely anechoic, but here the endometrioma or the chocolate cyst is gray. Okay. Look at this, it's gray. The ovaries got lesion that is gray or ground glass. Okay. Look at this. The cyst is black, but here chocolate cyst or the endometrioma is gray. Look at this. This is different appearances of how it looks. It is gray. Now, just as in the hemorrhagic cyst, this is a cyst, so it is an adnexal cystic mass with homogeneous or ground glass appearance, but it does not have vascular flow. Again, no vascular flow. This is important. This is like the hemorrhagic. Again, there is no vascular component. Now, it might exhibit some other appearances as in the clot retraction, but again, there is no vascular flow. Now, this is important. We said the hemorrhagic cyst does have clot retraction, but the rest of the cyst was what? Was anechoic. Remember when I told you the fluid level or the clot retraction, the part you've got part that's fairly echogenic, okay? The other part, rest of the other part was the hemorrhagic cyst black, but here and the chocolate cyst or the endometrioma, it is gray. Remember, I told you the chocolate cyst or the endometrioma has got the word gray all over its face. Now, everything related to it is gray. So this is the discriminating factor, but the rest of it is gray. Now, what would the patient suffer from? You know, she would suffer from something very peculiar to the endometriosis. Now, what is this? Okay. Remember that we said that there is the endometrial cells that is migrated to the ovary. Being endometrial cells, it would exhibit, just like its mother cells, changes every month, every cycle. So it would bleed. It would bleed every month. Okay, resulting in this hemorrhage inside of this being the chocolate system large, and it would reduce pain in the side it is present, in the side in which it is present. So the patient would suffer from that every cycle. She's got an increasing pain in certain side, This would confirm that she has something wrong in this side. And when we look by the ultrasound, might just say this endometrium. Now, yeah, this is hemorrhage. Yeah, there is hemorrhage inside. So yeah, it can exhibit changes, as in the hemorrhagic cyst can have clot retraction, have fluid level again, but the rest of the cyst would be gray. Remember, this is the discriminating factor. Here, this is the hemorrhagic cyst with the clot, and here is the hemorrhagic cyst with the clot as well. But the difference is in what the rest of the cyst here. The rest of the cyst is fairly black or an anechoic, and the rest of the cyst here is what? Always remember, gray. So this means that this is an endometrioma and this is just a hemorrhagic cyst. Okay? So this is the discriminating factor between the two of them, and the same would apply in the appearance of fluid as well. Look at this. Now this is gray, and it does have clot retraction. Okay. All right. This is a clot retraction. This is a clot, but is this a hemorrhagic cyst or an endometrioma? We would look at the rest here. Now it is gray. Okay, congratulations. This is an endometrioma. Would we just stop here? No, it's based on the most important thing. Is there vascularity inside or not? Okay. Voila. It is what? It is a tumor. It is not hemorrhagic cyst, and it is not a chocolate cyst or an endometrioma. This is a tumor. Yeah, it is an endometrial tumor, but doesn't matter. What matters is the prognosis here changes really, really much. So the important thing is that you would detect that this is being a tumor. Too important, it's not important its type as much as it's being a tumor. Okay, so do not forget to check the vascularity. This is the most important thing in all of the ovarian lesions, that you detect that this is a tumor, not just a cyst, whether it is a hemorrhagic cyst or an endometrioma. Okay, in all cases, you have to make sure whether there's vascularity inside or not. Look at this. We've got this gray part. Yeah, this is an endometrioma, and there's some cystic changes here. Okay, this is so well, it can happen. But the most important thing also to make sure that this is not a tumor. There is no vascularity inside. Now look at this. We've got this the appearance of the fluid level here on the endometrioma, and as we said, we would know that this endometrioma and not a hemorrhagic cyst, because the rest of the cyst here is gray. Okay, but why does it look as such? Okay, why does it look as such? The fluid level, why does it look as such? Okay, I'll tell you some tip here. Okay, if this is a transvaginal, okay, then what is this approach? Here would be caudal. This is the patient's feet. Remember, okay, remember when we have imagined the 3D rendering of the ultrasound previous lecture. So here was the patient's feet, and this would make towards her head. This is the phallic. In other words, this is inferior, this is superior. And if the area of lighter is here, this would make this the anterior and this the posterior. Okay, so yeah, this how the cyst looks is logical because this is the sedimentation would be towards the patient's back. So yeah, this is how it looks. While in the transabdominal approach, the sedimentation would be towards the patient's back, which would mean it would look as such in the picture because this is the orientation of the transabdominal. Okay, the patient's back would be towards the lower part of the picture, but here the patient's back towards this side of the picture. Okay, so yeah, it's important to imagine how the structure look inside the patient. Okay, as in relation to your role and how it is placed. Okay, in relation to the patient's body. Okay, so if you manage to imagine this is just as well. Okay. So again, in order to make things very clear, you've got hemorrhagic cyst exhibiting fluid level as such. The part that is echogenic would look as such. And this is the part that is echogenic, this tend to be darker, would be what? Almost anechoic, that's to say dark. But in the endometrium or the chocolate cyst, it would be the what? The gray. It would be gray. Always remember it. Most would exhibit this thing as sedimentation, okay, but the hemorrhagic cyst would be darker or anechoic, and here it would be almost gray. Okay. All right. Okay. All right. There is this thing, that this is another tip, it's not so very important, but then here the endometrioma would exhibit bleeding, okay, and the repeated bleeding will produce adhesions and render the two ovaries adherent to each other to make them look as such. They sometimes name it the kissing ovaries, and there might be pelvic adhesions resulting from the repeated bleeding. Okay, it's just a extra tip. Okay, here is got the ovaries, yeah, with adhesions, because yeah, it can be bilateral. Okay, to sum things up, now we've got this simple cyst, which is completely anechoic with posterior involvement, nothing inside. Got here the hemorrhagic cyst, lacy appearance, okay, and there's a ring of fire outside, just like a corpus luteum, but it's big, it's a hemorrhagic corpus luteum cyst. It's got this lacy appearance. We've got here the endometrioma that is gray, and it can't resemble some cystic changes, but the rest of it will be gray. Okay. So the appearance of the endometrioma, it is ground gloss as such, can be blood retraction, fluid level, or some cystic changes as such. The hemorrhagic cyst can be lacy or with blood retraction or fluid level. So they are similar, but the difference would be what the rest of it is, gray or brown gloss. Okay, this is the discriminating factor between two. And remember, very, very important that to check in both categories, whether it is hemorrhagic or endometrioma chocolate cyst, that there is no vascular flow inside. Now, what would happen if I see a endometrioma or chocolate cyst, just like the previous one, the hemorrhagic cyst? I will place the patient, whether it is low risk or high risk, and accordingly, I would tell her what to do. Okay. In this chart, there's something mentioned here, the echogenic foci, to change the prognosis, and it's worth mentioning. You see, so these blue echogenic spots inside the endometrioma, this would change the prognosis, okay? All right, so it's worth mentioning if you see these echogenic foci, all right? Okay, so it's worth mentioning because it will change, okay? I'll show you. Yeah, voila. This would, if you see this echogenic foci, this make the prognosis a little better. So it's worth mentioning, okay? You know, you don't need to remember this, just print it out, okay? All of these shorts, and you don't need really to memorize all of this. Okay? Okay. All right. Now to the third category here, the teratoma or the dermolysis. Now, this is the third cyst we have in this lecture. And this cyst, this pathology is rather very unique. And the teratoma or the dermolysis, we would see different parts of the body exhibited into this lesion. We might see skin, we might see teeth, we might see hair, we might see fats. Okay, so this is a very interesting lesion, and it can hardly be diagnosed because it has so many components as such, it can be misdiagnosed. Okay, so this is the uterus, and there's something here. You can just pass it by and say, okay, this is nothing. It's harder to diagnose it. It's harder to see it because it looks like just the bowel. It looks like nothing because it has too many components inside. Okay, so it doesn't have certain feature. You might just bypass it. I don't see it. Now let's try to decipher things slowly. In order to know that this is not bowel, okay, just relax a little bit and put your probe and stay put for seconds. If you see motion inside such, then it is bowel. Okay, so the dermoid will not have, of course, this motion, this static feature. So if you see a lesion, okay, and you suspect that being dermoid or something, and you don't know whether it is lesion in the first place or just bowel, okay, stay put for a couple of seconds and try to determine whether there is motion inside or not. Again, here we see motion. All right, that this is bowel. Okay. Again, there is motion inside. Oh, voila, something moving inside. This is static movement. So if you see a lesion, you have to exclude first being bowel, and you can exclude bowel by the fact that bowel exhibit peristaltic movements. Okay, how to diagnose the dermoid? Let's take things step by step as we usually do. We will see a complex lesion, of course, all about today's lecture is about complex cystic lesions. So in this complex cystic lesion, it's not 100% cystic anechoic and stuff like this. Okay, the dermoid would exhibit a hyperechoic part, almost white part. This is the discriminating factor. So that the chocolate cyst or the endometrioma has a gray part. The dermoid would exhibit a white part or a hyperechoic part. Okay? All right. So first thing we might see that will help us to determine this is a dermoid, that we would see white lesion inside or hyperechoic. Okay? All right. This is due to the fact that it has fatty content. Remember, in the myometrium, when there was fibroid that has a phagenic part inside, might be calcification of the fibroid or fibroid with fatty changes. Here, the dermoid would exhibit this white part due to the fat content inside it. Okay, so yeah, this is a cystic lesion with white lesion inside or hyperechoic part. Right, again, this is a lesion that exhibits some white part inside or some hyperechoic part inside. Okay, again, there is no vascular flow inside. This is really very important. Okay, there is no vascular flow inside. The second important feature here that you might see is that it does exhibit these small little shadows Remember when you said that the hemorrhagic cyst exhibits these lacy appearance, but they are connected to each other and they're connected to the wall. In contrast with this was the lesion we were comparing with. Here we see just these little, almost hair-like, and in fact, they exhibit and they represent hair, because the dermoid cyst, when we see the histopathology, does contain hair. So yeah, this is the hair shadow, okay, we see in the dermoid. Yeah, so when we see small septations, okay, this can strongly suggest the dermoid, all right? Voila, this is the histopathology. You see the parts of it, and yeah, these are really hair. And this is the fatty part. Fatty part and parts that is completely cystic, and parts with the fat, and parts with the hair. It has mix inside, okay? So this is dermoid cyst again, like the echogenic part, and it's got the hair, can have both features, okay? So yeah, this is dermoid. Okay, this is a complex cystic structure, cystic parts, hair-like appearance, and solid fatty parts. Okay, another example. Okay, all right. Okay, all right. All of these are examples so that you can train your eyes. This is the comparison between the hemorrhagic cysts. See that these are connected to each other and reaching the wall. So this is the threads of the fibrin, or this is the lacy appearance of the hemorrhage. This is a hemorrhagic cyst. But these are small echoes or small shadows. These are the hairs of the dermoid cyst. Okay, so we see them one side by side in order to differentiate them. Okay. The third thing that we can see areas of acoustic shadowing. All right, can have teeth inside. This is acoustic shadowing. Look at this. Look at this. This is a progenic structure that has posterior shadowing inside a cystic lesion in the ovary. This also highly suggests the dermoid. So the dermoid can have hyperechoic white part, can have hair shadows, and can have this areas of acoustic shadowing. Okay, third feature that we can see in the dermoid. All right, acoustic shadowing. Okay, the true shadow inside. Okay, here, shadowing, mix of components inside. Now, the fourth appearance would be the fluid level. But in contrast to the fluid level, we have seen in the chocolate cyst or in the hemorrhagic cyst, here the echogenic part is upwards. Why is such? Because this is fat. And as we know, fat floats. You can remember it as such. Fat float. So it will always be in the superior part of your picture. Now, of course, according to the orientation of your patient, as we said, this is the transabdominal view. Then the back of the patient would be towards the lower part of the picture, and the upper part of the picture would be towards the anterior part, and thus the fat will appear floating as such, which will make us sure that this is fat. Okay, if it is sedimentation in the chocolate cyst or the hemorrhagic cyst, then it will be towards the back of the patient. But this is against gravity, because why? This is not sedimentation, actually this is fat. So the fluid level here would be quite the reverse of the previous two lesions. And of course, we said that we can differentiate the hemorrhagic cyst again from the endometrium, but the fact that it is gray. Okay. Voila, look at this. This is in contrast with the hemorrhagic cyst, where the sedimentation is in the lower part. Okay. Again, here the fat flows. Okay. All right. Now, this is a comparison between the three appearances of the fluid level in the lesions we've discussed. Here in the hemorrhagic ovarian and in the endometrium or the chocolate cyst, sedimentation will be towards the back of the patient because this is sedimentation of blood. Okay, so it will be towards gravity. But to differentiate these two from each other, the upper part that is darker part will be completely dark anechoic in the hemorrhagic cyst, and it would be gray, as we just said, okay, that there is everything related to the endometrium is gray. And here, they reverse from these two. It's not sedimentation, thus the light part or the hyperechoic part is actually superior, because here, this is not a sedimentation as in the previous two lesions. This is fat, and remember, fat floats. Okay, so these are comparison. As usual, we put things side by side in order to remember the differences and be absolutely crystal clear about them. Okay, so you can know which is which. Okay, now what about this? What about this? Here, the dark part, is it gray or anechoic and gray? This is gray, so this is an endometrioma. Okay. Now, the fifth appearance of a dermoid, it can resemble what is known by fat balls, and this is fairly diagnostic, the fat balls. If I see fat balls, I would be very, very sure that this is a dermoid. Okay, so the fat balls has got no differential diagnosis. This is diagnostic. Okay, in other words, it is pathognomonic. So sum things up. The dermoid can have what? First things, anchogenic white part. Okay, fatty component. Second thing, the small curved shadows. And the third thing, it can have the posterior coasting shadowing, that's to say the calcification, and this is to the fatty content. And then can exhibit fluid level, but again, due to the fat will float. It will be in the superior part of the lesion, hence the gravity. And the pathognomonic here, the fat balls. All of these are appearances of the dermoid. Okay. And this is how we can manage to diagnose this difficult lesion. Okay. Voila, this is the fat balls. Okay, this is by MRI. Look at the pathology. Oh, voila, look how they look. The balls, exactly the same. Fat balls. And look at this, just as like in the fluid level, the fat balls will float because the fat always floats. Look at this, the fat will float. Of course, it's according to the orientation of the patient. Look at this. This might be a dent or teeth. Now, in the MRI too, you can, from the ultrasound, say that this is fat balls because and they float. Now you know why they appear as such, because the patient's backing towards the lower part of the picture. Look at these. Okay, if you are in doubt, okay, you can have even single cut by the CT in order to make sure. And you can see something such, the teeth inside, and be very sure that this is a dermoid. And you can see the fatty content also by the CT. It look very hyperdense as such, with very dense calcific shadow as such that would be teeth. Then you can be very sure that this is a dermoid. It also appears by the X-ray, and it's one of the differential diagnoses of calcific shadow and the pelvis. And this could be in the examinations of spotting the exam. What produces this specific shadow? What produces specific shadow of the pelvis? It can be a calcified fibroid. Okay. It can be a dermoid cyst, as in here, that has some teeth inside. It can be a stone in the ureter if it is aligned with the course of the ureter. Okay, and it can be a Philip polyp. Okay, so this is the differential diagnosis of specific shadow in the pelvis by the X-ray. Okay, all right. Patients might have one teeth as such or multiple teeth. Look at the teeth. They just look like the molars. They have two roots and the upper part looks exactly like molars. Okay, so again, this is how the dermoid cyst would appear. Okay, this is a sum up of how they would look. Now we have got this white echogenic part, with hair-like shadows, the fluid level, but where the fat will float, mix of the white part along with hair shadows, posterior acoustic shadowing, and the diagnostic fat balls. Okay, all right, all right. Here, this is the simple cyst. Here is the hemorrhagic cyst, and this is gray. So what it would be? Voila, it would be endometrium or chocolate cyst. And this is white, echogenic part, the white, solid and cystic with hair-like structures. Again, dermoid. Again, dermoid. Okay. Here, there's two ovaries, and it has two lesions. See this lesion here, it has lacy appearance, but the laces are connected together. This is likely to be a hemorrhagic cyst, and here the cyst is got white echogenic part, so it's likely to be dermoid. Which might have double pathology. Okay, bravo. Okay, now we're going to go some cases, okay, various cases in order to revise things together. Now, what is this position of the uterus? See this uterus. Okay, the uterus as in such. This is the uterus. Now, where is the fundus? Or the fundus is looking where? Towards the rectum. Bravo. So this is a retroverted uterus. Bravo. Okay. But try and test yourself and write the answers down and see how much you get right. See, now we have two endometrial cavities. Okay, they are unequal. Now, what is this? Voila, look at this 3D rendering. This is a unicornary uterus with functioning cord. Okay, now look at this. There is indentations inside the myometrium. This is the adenomyosis. The endometrial cells has migrated inside the myometrium, causing this. Look at this. This is a cystic structure in the ovary. Okay, it is a nexal lesion, and you see this echogenic part. This is this. Absolutely right. Bravo. This is a dermoid cyst. Bravo. Look at this. This is the shell cavity, and I see this structure here. Okay, this structure here. So apparently this is the IOD. Is it in its place? No, it is well placed, and most importantly, also it is where it is embedded in the uterus. So it's not just low lying, it is embedded as well. Worth mentioning, of course. Okay. Next. Next. This patient's coming with primary infertility, and the uterus looks as such. This is a septate uterus. What about this uterus? What about the position? Okay, this is anteverted but retroflexive. It's looking the other side, but it's not looking towards the rectum, downwards here. It's just not anteverted towards the uterine bladder. So this is retroverted. Sorry, retroflexed uterus, but it is still anteverted. Okay, anteverted, retroflexed. What about this in today's lecture? What about this? This is the next lesion. Huh? What does it look? What is color? Who has got certain color on his face? That's gray. Yeah, it's endometrioma. Remember, endometrioma always looks gray. What about this? By the MRI, see these cystic structures inside the endometrium that looks such. This, of course, adenosis. What about this? This is the next structure. A patient suffering from pain and the left iliac fossa certain side. And look at this. She's got this lacy appearance, like net, like the spiral. This is gravel. This is the vaginal cyst with the lacy appearance or reticular appearance. Okay. Now, there's a certain remark that just tell you very rapidly managed to get it, and it's okay, just as well. We will go back to certain slide. Okay. It's really just very good tip. Okay. Something called decidualized endometrium. Okay, what is this? Let's see. Voila. That is it. Now, when the patient has endometrioma and she's pregnant, now there will be increased vascularity with this endometrioma. And so I might say endometrioma with vascularity itself. Now, this is related to its being resembling of the mediastidua of the uterus, okay? This is a very special case, and I'm just mentioning it so that you know it, but it's not very important in the clinical practice, okay? Look at this. This is the ovary of a pregnant female. And look at this. Exhibits vascular flow inside because here endometrioma will exhibit changes as in the residua of the mother endometrial cells. Just a typical. Okay. Let's go back to the quiz. Okay. Let's go back to there. Okay. Voila. Now, this patient has a pelvic swelling. Okay. Now, we've got this mass. It looks sustained. And the echogenic part is in the upper part of the cystic mass. Now, it looks as if it's floating. Why? Which reminds you of what? Absolutely correct. It's dermoid cyst when the fat floats. Okay. Bravo. So far, so good. Now, what about this? It's an ovary as well. Small cystic structure. It's got the stellate inside. This is a corpus luteum. Okay. What about this? There is a fluid level. This is an adnexal lesion. What would it be? Look at the rest of the lesion. The cyst. Looks what? Huh? Gray. Gray then? Voila. Then it is endometrioma or chocolate cyst. Look at this. This is a patient post-menopausal. Post-menopausal bleeding. This is an endometrial cavity. This is right away an endometrial carcinoma. Look at this. Patient's got double uterus. This is diadelphys. Looking this with the hysterosalpingography. Patient's got something inside. Okay, if it's removed, this is a case of secondary infertility. And if it's removed, patient might just be fertile again. And this is a case of adhesions or synechia or Usherman syndrome. And this is a real case when the patient has really become pregnant again after removing this by the microscope. Okay, what about this? This is a lesion, okay, and the myometrium with some echogenic part inside. This is fibroid with hyaline changes or fatty changes, okay? What about this? The patient has got vaginal bleeding, and after injecting water, I see this thickening. This is endometrial hyperplasia. What about this IOD? Is it in place? No, it is no line. Okay. What about this? This is, yeah, this is again adenomyosis. What about this? This is, I see the cystic structures inside, and after activating the Doppler, these are arcuate vessels. Bravo. This is quite diagnostic. The fatty bones. These are, yeah, the dermoid. Bravo. What about this? This is endometrium, the uterus, and the endometrium exhibiting these remnants. Which phase of the cycle? Yeah, this is the early menses phase. Patients in her period or menses. The patient suffers from adnexal lesion, and I see this lesion. Okay, it's related to the uterus. This is actually subserous fibroid. Bravo. What about this? This is adnexal mass, and I see this mass in the ovary. Huh, what does it exhibit? Yeah? Bravo. Small hair-like structures. This is the dermoid. What about this? This is, bravo, an endometrial polyp. The cyst within system. This is the ovary. So this is what? This is the follicle with the cyst inside. The cyst within cyst. Okay. This is uterus with two cavities. This is 5-cornered uterus. Okay. The patient suffering from adnexal pain. Which type of cyst is this? Yeah. Here I see that this is cyst and there is some part in it and the other part, and then I activated the Doppler. Okay. This is it a simple cyst? No, it's not simple cyst. It is a cyst, yeah, but it has components inside. So firstly, this is a complicated cyst. Okay, and it has some part in it which might be soft tissue or not, soft tissue lesion, like tumor. Tumor, okay, the vascularity. Does it have vascularity inside? Well, no. Then this is what? This is a hemorrhagic cyst because the rest of it is black. If it was gray, then it would be chocolate cyst or endometrioma. So this is just hemorrhagic cyst, no vascular flow inside. And so the patient has a hemorrhagic cyst with clots, okay? Okay, so this is hemorrhagic with clots. Now, which phase of the cycle is this? This is early secretory. Bravo, because starting to see this progesterone periphery. Okay, what are these tubular structures? We activated the Doppler and voila, this is an AVM. That was the last case. Stay tuned for the third part and hope that you've got it right and well. And thank you for listening.